burns. From notes by Dr. Hesham Wajeh. Edited by Dr. Mosi Tahi. Types of burns. Following are the types of burns. 1. Epidermal, also known as superficial burn. 2. Superficial partial thickness burn. 3. Deep partial thickness burn. 4. Full thickness burn. 1. Epidermal, also known as superficial burn. Epidermis is red, moist with blanching. 2. Superficial partial thickness. Epidermis and part of papillary dermis affected. Pale. Dry with blanching. Normally heals with no intervention. 3. Deep partial thickness. Epidermis, whole papillary dermis affected. Mottled red color. No blanching. Needs surgical intervention, depending on site. 4. Full thickness. Whole skin layer and subcutaneous tissue is affected. Dry. Leathery hard wound. No blanching. Should be managed in burn center. Depth of burn can be assessed by following points. Bleeding on needle prick. Sensation at the site of burn. Appearance. Blanching to pressure. Percentage assessment of burns. Lund-Browder chart and Wallace rule of nines. Lund-Browder chart, most accurate even in children. Wallace rule of nines, palmar surface, surface area palm equals 0.8 to 1% burn. If greater than 15% body surface area burns in adults, needs urgent burn fluid resuscitation. Indications for transfer to burn center. 1. Adult more than 20% total body surface area, 2nd or 3rd degree, or greater than 5% full thickness, 3rd degree, burns. 2. Injuries to specific body areas, for example eyes, ears, face, hands, genitalia, associated inhalatio injury. 3. Significant electrical or chemical burns. 4. Any child, less than 10 years, with partial or full thickness burns greater than 10% total body surface area. Escharotomy. Indicated in circumferential full thickness burns to the torso or limbs. Careful division of the encasing band of burn tissue will potentially improve ventilation, if the burn involves the torso, or relieve compartment syndrome and edema, where a limb is involved. Pathology of the burns. Extensive burns. 1. Hemolysis due to damage of erythrocytes by heat and microangiopathy. With loss of capillary membrane integrity causing plasma leakage into interstitial space and extravasation of fluids from the burn site causing hypovolemic shock, up to 48 hours after injury, decreased blood volume and increased hematocrit. 2. Protein loss. 3. Secondary infection, for example Staphylococcus aureus. 4. Acute respiratory distress syndrome. 5. Risk of Curling's ulcer, acute peptic stress ulcers. 6. Danger of full-thickness circumferential burns in an extremity, as these may develop compartment syndrome. Healing of the burns. 1. Superficial burns. Keratinocytes migrate to form a new layer over the burn site. 2 full thickness burns, dermal scarring. Usually need keratinocytes from skin grafts to provide optimal coverage. Fluid resuscitation in burns. Indication: greater than 15% total body surface area burnt in adults and greater than 10% in children's. The main aim of fluid resuscitation in burns is to prevent the burn deepening. Most fluid is lost 24 hours after injury. First 8 to 12 hours fluid shifts from intravascular to interstitial fluid compartments. Therefore circulatory volume can be compromised. However, fluid resuscitation causes more fluid into the interstitial compartment, especially colloids. Therefore avoid in first 8 to 24 hours. Protein loss occurs. Thank you. Kindly subscribe the channel Med Exam Prep Hub for more videos. And join Dr. Hesham's MRCS notes on Telegram.